All right, guys. I hope I am recording. I never am very good at this. But anyway, I'm exhausted. It's been a heck of a week. I just saw all my patients, and now you get the privilege of coming to my office for the recording on addictions, which uh I mean it's pretty much gonna, be I can't even think. Anyway, I'll just get into it and we'll talk about it as we go along. Let's see, share my screen. Where's my screens? That is weird. Okay, hang on. Let me shrink this down, see if I can find out where it went. Why did you disappear? I don't know. All right, let's go back here and get bigger. And now let's try this. So then recording, so we're good. Okay, share my screen. Here we go. Sharing my screen. And presentation mode. There we go. So addictions. Addictions, there are some that are legal, there are some that are not legal, there are some that are becoming legal, but it doesn't matter what the actual addiction is. Um, if it's regular or legal or not legal, it really doesn't matter. It's something that happens in the body, is what an actual addiction is. The thing that you become addicted to is an addictive substance. So, that being said, it is a big problem in the United States, so it's difficult to determine how big of a problem though, because some things, like I said, are legal, so they don't really count those as being um, a cause of death or an issue when they can cause it to something else. Like if I have a food addiction, just say just because and it causes me to have diabetes. And then my diabetes causes my heart to fail, and I have a heart attack and die. My cause of death will be um, heart failure or MI. It won't be diabetes, and it won't be my food addiction. So that's pretty much the reason they can't say which is which and what's going to happen, but it's detrimental to everybody. Economy wise, people can't go to work, even if they're functional. A lot of them choose not to. Fatalities, motor vehicle accidents, prenatal drug exposure. I know when I was dealing with my rehab in Dayton, I had several new moms who were recovering and they were living there first 28 days after the birth of their child was with them, of course, in a bassinet beside the bed. Most of the time, I ended up holding the babies because they really were suffering. So, anyway, it's a very real problem. Children of alcoholics are more likely to develop alcoholic problems. You have to have a conscious effort not to go that way. 50% of all traffic problems have alcohol involved. I don't know that that statistic has changed since marijuana has become legal, but it does cause an influence or a change in mentation. So 20% of suicides are alcoholics, and 30% of alcoholic deaths are suicides are related to accidents. So that's kind of combining them for you. Some terms. We talked about the addictive substance. Intoxication. Intoxication is reaching the maximal amount of euphoria or the desired effect related to the ingestion of the addictive substance. Uh, Withdrawal, everybody should know what withdrawal is. So withdrawal is your body's kind of rebellion against not having the addictive substance. Withdrawal is the result of detoxification. Detoxification is where you stop taking and your body is releasing all the toxins that the alcohol caused or the addictive substance caused. And then you have a reaction in your body related to the lack of those substances, which is withdrawal. Substance abuse is different than substance dependence. And I know I really can't see this, and I don't know why this is doing this to me, but substance, there it is. Put it up here. Substance abuse and substance dependence are different things. Like somebody who has cancer, they're dependent upon the morphine because they need to have that to have pain relief. And that's acceptable. They're dependent on it. But if their family member sees them taking it and decides to take the morphine for fun, then that's substance abuse. It's using an intoxicating substance for a purpose unintended. So, okay. We have alcohol, which of course we're going to talk about the most probably. We have sedatives, hypnotics, and anxiolytics, stimulants, cannabis, opiates, hallucinogens, and inhalants. And you're going to see some of these in the emergency room as they come in, either in detox or as they come in intoxication or overdosing. Everybody knows about drinking. If not, you've had some experience with others who have been drinking in your presence. The problem with alcoholism is that it is or people who are alcoholics, is that they have acquired a tolerance to increased levels of ETOH, which is alcohol, ethyl alcohol. And it's that part, the ethyl alcohol, the ethyl part that Antabuse works on, which means you got to have it in your body, alcohol, for the Antabuse to, well, I don't want to say to work, but you're going to, if you're drinking and it's in your body and you use Antabuse, you're going to be sick. It's going to be dangerous side effects related to the use of that drug. Also, if you don't drink or you haven't drank, or if you have a drink and you're on Antabuse, it's going to affect you when the alcohol gets into your bloodstream, not before. Okay, so just kind of keep that in mind. It's a horrible drug. Alcohol, not Antabuse. Antabuse, good stuff. Okay. Some biological etiology, biological factors. Some people say alcoholics is an addiction related to genetics. I don't know if it's a nature nurture, if it's in your genetic scheme to become an alcoholic. I do know there are some cultures like the Native Americans who are more prone to become an alcoholic, but I don't know if that's a lack of protective factors or what. But that's statistically, we have Caucasians, Hispanics, Blacks, everybody has that protectant factor that nature can overcome, I suppose, through coping styles or family dynamics. So that's your nurture part. And of course, culture impacts it, social attitudes. Everybody knows drinking is legal, it's perfectly okay. In high school, I know a lot of people these days don't drink, but back in my day, there was a lot of alcoholism among the kids. Laws, we do have definitely 0.08 is your level of intoxication. I don't know if they've come up with anything as far as like other drugs, as far as a blood level test. I don't know that they can do blood level tests on some of those other drugs. But I guess that's just all we're going to see coming. Okay. Interestingly, Muslims don't drink, do not drink. So there's no alcohol at all involved in their belief system. Whereas I'm a Catholic, so we have wine with everything. Jewish also have wine related to their religious rites. Native American tribes, there's a few of them out in the West. who use peyote, but I'm not sure which tribe. I don't think it really matters, but it is a hallucinogen. So, and it's acceptable, it's legal for that tribe, legal on the reservation. It's not legal out and about. And then in most of your European cultures, as well as Japan, alcohol is a beverage. I know in Germany, a lot of times drinking age is 16. You have this beverage choice with your meal. And so it's not considered a drug. Alcohol is not considered a drug. It's a beverage for those cultures. We kind of already talked about this. The various enzymatic activity, Asians, Africans, Americans, Caucasians, or white people, we have those protectant variants against alcoholism, where the fifth leading cause of death for Native Americans is alcoholism. So they lack that protectant factor. Okay, so let's talk about alcohol. Alcohol is a depressant, causes relaxation and loss of inhibition. If you take it to excess, you get respiratory depression, vomiting, unconsciousness, and if you vomit while you're unconscious, you can aspirate and die. A lot of rock stars have done this over the years. Anymore, I think started in the 80s and 90s. It started with heroin becoming the drug of choice versus drinking and then dying that way. But Kurt Cobain with his overdose probably started that all off. Whereas Bon Scott, back in the day with AC/DC, he actually vomited while he was passed out and aspirated and died. So we've come a long way, but that pretty much is where alcohol sits. It's a legal way to harm yourself. Symptoms of withdrawal. Withdrawal can happen, and you can withdraw from alcohol. If you've never seen an alcoholic, it's pretty sad, actually. They get the tremors, the shakes in the morning before they can get in to get a drink. And so that's beginning withdrawal. It can happen up to 4 hours to 12 hours. It's reason I say in the morning. Most people, if they're alcoholic, they've been drinking the night before, they wake up with the tremors or with the shakes until they get that drink in. Um, Peaks up on the second day, the withdrawal, it gets worse on the second day. Usually you're through it in about 5 days, but it can wreak havoc on your body until then. All the lovely hypertensive crises, things like that can happen during withdrawal with alcohol. Tachycardia, you just feel bad. Benzodiazepines, we can give them benzodiazepines, namely Librium. Somebody in my clinical group just did that. It's a good drug to use. We see it a lot, used a lot in alcoholism. So if you have a patient on Librium, you want to say to yourself, I wonder if they drink, and then look at their history. Okay, so is it a stimulant? No, it's a depressant. Sedative hypnotics and anxiolytics, they are really addicting, highly addicting. So we have to be very careful when we use those. We have benzodiazepines. We've already talked about those a little bit with the Librium. Overdose is rarely fatal, but some people do use those for fun. Barbiturate's the one you got to worry about. Barbiturates can cause cardiac failure. They can cause death. It just depends on which drug they've got. Like phenobarbital, people use those for seizures. That is not as bad as a barbiturate. It's like a pseudo barbiturate, but some of the heavier hitters, they really can do you a lot of damage. As you're withdrawing, you have the whole CNS fight or flight thing that happens. They start hallucinating. And you really, when you're detoxing off them, you want to leave them on it and just kind of work them down as much as you can if it's in a controlled situation. If it's not controlled, it's something they're over the counter. A lot of times it's going to be a cold turkey, but it's going to be possibly a medically induced coma to get their body through it. It just depends. I'm not going to talk specifics about these guys. Stimulants, cocaine. Methamphetamine. It is important to say here that if you see somebody who's positive for methamphetamine, or any kind of amphetamines, you want to make sure that they're not on Adderall or any stimulants like that for ADHD, because those will give a false positive for amphetamines. So something to think about when you're in the clinical setting. They are stimulants. They cause you to be hypervigilant, hyperactive. Um, but unfortunately, they can really make you sick. Withdrawal within hours, people will feel that withdrawal within hours. It can cause seizures. And then if you overdose, if you take too much meth, or if you take an overdose of Adderall, some people have done that, you can die. Withdrawal, vivid dreams. Those are the big things I hear people complain about. They say they have really vivid dreams. Some people say that they can't sleep. Some people say they sleep too much. But there really is nothing we can give them for withdrawal. It's it's not nice. You want to try and give them a lot of times. Permission to feel the way they feel, because the irritability is going to be horrible. So they're going to be the kind that are angry, screaming at you, yelling at you, banging their head against the wall, running around, just because they're so uncomfortable. And that's okay. They're allowed to feel that way as long as they don't impede upon other people. They're okay to do that, because we can't give them anything to help them with those feelings. Um, Marijuana is legal in Ohio. It is legal. Medical marijuana is legal. You can get it with a prescription, but recreational marijuana is becoming legal. It's been voted in, and I know we have a dispensary in Delphus, Delphus, Ohio. Drove past one, go, oh my God. But yeah, so it's used mainly for entertainment, if it's not for cancer, those kinds of things, or for a lot of times they use it. Well, I used Marinol for my patients, um, with Parkinson's, because of the horrible tremors they had. It caused them to lose excessive amounts of weight, and so Marinol, which is liquid marijuana, basically increased their appetite and allowed them to maintain their weight, even with the horrible tremors that Parkinson's had. So, um, as far as prescribing the smoking kind, or I don't know how you prepare it, the eating kind and brownies or whatnot, I've never done that. I've never prescribed that yet, but it's coming. You'll be able to do that. I imagine for some of the cancers, oh, probably the Parkinson's will be a good one. Maybe anorexia. I'm not really sure, but those are some things. You really can't overdose on marijuana unless you eat too many brownies, right, Grace? Anyway, now clinical significant withdrawal symptoms there, symptomatic treatment. So if they're hungry, feed them. Just kind of keep them grounded if they feel too high, and help them sleep it off. Opiates, they're the big ones these days. Heroin. Um, a while ago used to be OxyContin. That was a bad one. We still have oxycodone, which is okay. But you see naloxone being the treatment for these guys. They can cause respiratory depression and death, pupil constriction usually. Um, Lots of people, they call it nodding. If they're using heroin, they'll be like this. They call it nodding, and that's not, they're really not asleep. They're experiencing euphoria. Some people will, take as much heroin to cause them to nod, but also have some cocaine nearby to bring them up in case they feel themselves going too far over the edge. So then they can shoot, snort, whatever, to bring themselves back up again. Highball, I think they call that highball. Um, Opiates, heroin is measured in capsules. If you do addiction, or you do um, injectables with the heroin, um, a lot of times, um, You'll see it not only in the incubator, but you'll see it in the web spaces of the toes, things like that. You have to look for infection. There's something it's called cotton fever, because a lot of times what your addict will do, and this is in public restrooms, so be careful. What your addict will do is shoot up in the restroom and then clean their needle by sticking it in the toilet paper and pulling it out. You'll see little pinpoints in the toilet paper that look like they might have a little blood or something brown. Don't use that toilet paper, okay? Um, but the fibers from the paper actually get sucked into the syringe when they pull it back out again. So the next time they use that syringe, you have some microfibers from the toilet paper that they're injecting, and it can cause an infection, and it's called cotton fever. On the street, they call it cotton fever. In the hospital, we just call it an infection and sepsis. But if you hear that language, then they know that what they got, and they know how they got that. Um, we do see some nasty heroin out there, crocodile right now. It actually is necrotizing to the skin. So their skin basically is falling off wherever they do injections at. Um, bad drug, bad drug. Naloxone is the treatment for that. And if you have somebody comes in and they're nodding and there's no cocaine on board or nearby, you're going to have to give them naloxone because that's a total agonist and it will block the receptor sites. Now, there's a couple of different kinds that are out there besides naloxone that you can use. One of them is a partial, Suboxone is a partial antagonist. So a lot of people will use that if they can't get their drug. They will use that because it has addicting properties. There's methadone. Methadone they still have out there. We don't use that too much anymore though. And then there is the injectable, which is a complete agonist. God, I can't remember the name of that one. Can't remember the name of it. I'm not going to test you over it, but it's given dorsal gluteal, so you guys can't give it anyway. But it's a vesicant. So if you inject it and you don't get it into the dorsogluteal muscle, their butt cheek will pretty much fall off. It's nasty stuff. It's a total agonist too. So if they use while they're on it, it'll kill them. But unless you're going into addictions, don't worry about that one. Vivitrol. There it is, Vivitrol. Complete antagonist to the receptor site, so complete blocker. No matter how much they take, they won't get high, and they're gonna end up killing themselves on that stuff. So you gotta urine dips and things like that to make sure that they're clean before you prescribe that and allow them to inject. Anyway, but those are opiates in a nutshell. Just know naloxone is the treatment of choice these days, and we do have some at Bora. It is there right outside our classroom, 110. Withdrawal, real quick, can happen with like heroin within 6 hours of not having a dose. Um, most of the people I had, when they were coming into me, they were nodding, and I would put them into get some naloxone on board, and then get them settled into their rooms and such, and get them on my little cocktail. I gave Bentyl, Phenergan, and Vistarel. Bentyl for the stomach cramps and Phenergan for the nausea associated with withdrawal, and the Vistarel for the anxiety related to the withdrawal. That was my personal cocktail that I gave to my patients. And I'd give it to them for 2 weeks just to make sure that they were good, even though withdrawal symptoms, according to your textbook, say 7 days. I'd go all the way to 14. Methadone, those guys like we don't use too much anymore. That takes the 2 weeks, which is kind of probably where it's stuck in my mind to use the 2 weeks for my little cocktail for heroin. And maybe I overdid it, but when you want somebody off something and you want to take them off and you want them to feel good and stay off of it, you want to give them as much leeway as possible to help them help themselves. Okay. Um, Hallucinogens. Oh, these are fun. They distort reality. You really can't overdose on these guys, but ugh, they're not good. So they cause hallucinations, they can cause depersonalization, they can cause derealization, where they feel like nothing's real, or depersonalization, where they feel like they're not in their own body. PCP, LSD, those guys are man-made. We made those in the 50s and 60s. They're going to be used to heighten our soldiers' minds so that we could overcome our enemies when we were fighting with them. Unfortunately, they became recreational. PCP could cause hypertension, hypothermia. All of it causes respiratory depression, and all of it can kill you. Bad stuff. The big thing with these guys, no withdrawal, but you can have flashbacks. So let's say you drop some blotter, which is acid, comes on little square pieces of construction, look like construction paper, blue construction paper, they call it blotter, and they cut it into little tiny squares, and you put it in your mouth, under your tongue, and go on a little trip. Let's say you did that and you were like looking out the minute window and, oh, the trees are smiling at me. 5 years later, oh, the trees are smiling at me. It can come back. But it can be the opposite too. So, oh my God, they got a knife and they're coming to kill me. It's Eddie, whatever, Freddy Krueger, whatever. 5 years later, same thing. So just kind of keep in mind, flashbacks are forever. Um, I'll move slow here. Inhalants, these guys are fun. Yeah. I think back in my day, they called them whippets. I'm not sure. They're little like CO2 canisters. These days, when we see people who are using inhalants, they're called huffers. They put a bunch of stuff, bug spray, glue, anything they can huff in there. They put it in a brown paper bag, put it up over their mouth, and breathing in that way. The big thing about huffers, when you see them, they have sores like all around underneath their nose and sometimes down and around their mouth. And that's basically because that stuff that they're breathing in is real toxic to the skin and it can cause blisters and ulcerations. So, as you would think, with toxicity, you're going to see breathing problems, a lot of breathing problems, death because of bronchospasm, cardiac arrest, suffocation, aspiration. Not a lot we can do for withdrawal of that. Uh, just support how they're feeling. Okay. They're going to have a lot of brain issues too. So you do that much breathing in of RAID, I'm sure you're going to probably lose some brain cells. Person who abuses hallucinogens will experience a withdrawal symptom. Nope, no withdrawal, but we do have the flashbacks that can happen. Substance abuse treatment. The interesting thing about substance abuse, the impaired nurse, I want to tell you, is that all your states are different. Okay. They're going to let you continue to practice in most states if you've been found to be impaired. They're going to either offer some sort of support or refer you out to some sort of support. In the state of Ohio, they have their own impaired nurse support people. You're probably going to have a restricted license, but you're going to be allowed to work. You probably have to do a breathalyzer before you go to work or able to go into work. I know one of my former students, he was an LPN, and the board had him doing urine testing every week because he was positive for, I want to say, it wasn't alcohol. I'm wanting to think it was heroin. He had come up positive. He was using heroin, and they were allowing him to practice. He was still allowed to practice, but he had to be clean every week to maintain his license. So they did urine testing every week. He graduated with his RN, got his BSA, got his MSN after he got clean. He is a director of an inpatient, it's not a psych unit. Is it a hospice unit? I think it's a hospice unit, but an inpatient hospice unit in Florida. So we keep in touch. He's a nice guy. Yeah, I'll be your Facebook friend. It'll take you a couple years after you graduate, though. So if you want to be my Facebook friend, that's cool. But he's doing really well. And I always ask him, "Are you still clean?" He always says, "Yeah." He says it's rough. He's going to meetings, and he's really pushing it. Once an addict, always an addict. Doesn't matter how many years you're clean. So keep in mind, um, AA is a good support. It has 12 steps to it, and you have to work the program in order to get the benefits of it. If you're leaving the hospital and you've been an alcoholic, to maintain or to bridge that gap into outpatient sobriety, you have to go to an AA meeting as soon as you're discharged. I mean, within an hour of being discharged, ASAP meetings, and then regular follow-up every week. That's the only way you're going to stay clean, is working the system. Okay. Um, we can, say that individual therapies will work for substance abuse. Sometimes people find their dealers there. So group therapies are good, like NA is a good program. There are different treatment settings that are out there, clubhouse settings. I know we kind of talked about this in, I think it's chapter 3 of, Vitabeck, maybe chapter 5 of Morgan. We talked about some of these treatment settings that are out there. Some pharmacological treatment, whatever they're addicted to and they need help getting through, and preventing a relapse is what they need to do. So dual diagnosis is a language, it's a term that we use for somebody who has a mental illness plus an addiction. And this is probably about 90% of our homeless population is a dual diagnosis. Unfortunately, it does exist. We want to keep them clean, healthy, living in supportive environments. We want to help them with jobs, having support systems, people who are not using, connections with other recovering people, and treatment of comorbid conditions, because a lot of times the elderly tend to be a little bit older, and those comorbid conditions are pretty prevalent as we get older, as we age. So substance abuse. We want to look at the person who is addicted. We want to look at their family life. Was their father an alcoholic? Because remember previously we said that children of alcoholics are 4 times as likely to become alcoholics themselves. Is there something that happened that precipitated their exacerbation of drinking? Did they start drinking right away? How do they look? Are they put together? Are they disheveled? How is their motor behavior? Are they showing signs of withdrawal? We want to look at their mood. Are they labile? Which is a lot of times what you'll see in cocaine. You'll see them up and down and up and down and up and down. How's their affect? Are they crying? Do they feel angry? They have to talk to you. So are they willing to talk? Are they willing to accept the responsibility? Because they can't help themselves, or you can help them. They have to help themselves. So you really have to, if they say, I drink because, she's a horrible person. No, you drink because you drink. You don't drink because somebody else makes you drink. That is not an excuse. So they'll try to rationalize everything, and they're not ready to get clean when they're rationalizing things like that. When they admit there's a problem, that's the first step. Okay. So we look at their judgment, their impulsivity. That's really big in alcoholism. They just tend to drink. Their self-concept, their roles, and other physiological concerns. Like whenever I had somebody who came in who was using IV drugs, I would automatically check them for HIV and hepatitis. Oh, automatically, same panel, order them all. And, probably I would say it's probably 60% came back with at least one or the other for IV drug use. Liver damage, lung damage from the huffers, things you got to look at. Then we make our diagnoses. and related to substance use, because that's something you can do something about. We need to help them stay away from alcohol and drugs, but we can't make them, but we have to assist them. We can help them accept their own responsibilities for their own behavior. We can teach them non-chemical coping and help form plans with them for after they get out. Okay. So a person who abuses substances will commonly state that he or she can control or use their use of the substance. They will always say that. I can stop anytime I want. That's true. They'll say that, but they're in denial. Okay, so interventions that we can use, lots of health teaching, lots of looking at the family, including codependency and enabling. Buying alcohol for an alcoholic is enabling them. Okay, it's allowing them to do it. Being codependent is just dysfunctional, how the family functions in a dysfunctional way. Okay, teaching coping skills that do not involve alcohol. And then, was your teaching effective? Did it work? How are you going to measure it? Some things you're going to think about. A lot of times you're going to see these guys, and I know up at 4E, well, 7E, sorry, that IOP room that we use, a lot of those people that come back through there are people who have addictions. They're sitting in there. That's one of their groups to help them stay clean. So just kind of think about that. It's kind of why I stay out of that space, because they need that space. They need to be there. 60% of elders began drinking abusively after the age of 60, so 30 to 60%. I think it's a little higher. I think it's somewhere between 50 and 80%. They start abusing after the age of 60. And if you think about the reasons potentially why they drink, there's a lot of them. Risk factors, chronic illness, pain, long-term use of prescription medications. Like I've said before, if I have a little 80-year-old woman on Xanax, I'm not going to take her Xanax. Okay. If she's drinking and causing harm to her liver and somebody else because she's still driving, then that's a different story. Losses, not dealing positively, because remember, our goal with the elderly is help them attain positive reflection of life. They look back and they say, hey, I had a pretty good life, not just, disgust, self-disgust. So also, as you're older, you tend to develop more physical problems more quickly. Community-based care, lots of things that are out there. Self-help programs, these are the best. These are the best, okay? We can do individual and family counseling, but usually for addictions, the self-help programs work even better than that. And lots and lots and lots of education for the public. As nurses, it's our responsibility to help educate the public. We want to make sure that people know about alcoholism and how deadly it is. We want to know from college kids with the hazing and the drinking to the elders, senior citizens and things like that, how dangerous alcohol and other addictions can be. And we kind of already talked about this, what to do with the different states. It's your responsibility to report an impaired coworker. Now, how they're impaired really doesn't matter. The fact is they can't do the job. Okay, so you may not smell it on them, but you may see that they are not at work, or they show up late, or they have slurred speech, or they look unkept, or they stay away from other people. And when you see that, you can report that behavior to your manager. Don't talk to the person themselves and say, hey man, don't drink before you come to work, because then it becomes personal, one-to-one. You guys are friends, right? Go to your manager, and report only what you see. You don't want to report, I think this because they said this. No, only what you see, and then let your manager handle it, because it can be a highly volatile situation. And then you have to realize how you feel about alcoholism and how you think about drugs and alcohol. I don't think any nurse, if you have a need for medical marijuana, let's say you have breast cancer or something, and you're a working nurse, I don't have a problem with that. Okay. Use it on your own time. Don't come into work impaired. You come into work impaired, I'm gonna tell on you. You won't have a job for long. Okay. So just kind of be smart about it. Just don't come impaired to work. Recognize that substance is chronic illness. Substance abuse is an illness. The first time you use any substance, it's a choice. After you use that, your brain chemistry changes. Those addiction centers, the dopamine receptors, the serotonin receptors, those are your reward receptors. Those become activated and crave the substance if you have that propensity. Now, after you've used the first time, you no longer have a choice. You will always use, which is why I say once an addict, always an addict. You can choose not to use the substance at all. But most Americans say, hey, let's give it a go. Let's try it out. Until we figure out a way to educate people on that, besides the DARE programs, which have pretty much become a joke, I don't think we'll ever get a handle on addiction. Okay. Oh, and I think that's it. Okay. So there's a quiz in a nutshell. And there is your lecture. Sorry it took so long. Like I said, it's been a week from heck. And I'm going to go home now and I'm going to, what time is it? Oh, it's almost 5. I'm going to go home now and I'm going to climb into bed and not move until Monday. I want to see you again. And we talk about personality disorders, which are fun. So until then, good luck and I'll see you Monday. Bye.